I would now like to move forward to the session 2. I cordially invite Dr. R.K. Bakshi, former professor in the Department of Preventive and Social Medicine, Medical College, Baroda, and Dr. Arun Gupta, Central Coordinator of VPNI India, to chair the session. I would request all the speakers to stick to the time limit of 15 minutes for the presentation. I would now request Dr. Bakshi to introduce our first speaker, Dr. Sebanti Ghosh. Over to you, sir.
Yeah, screen share, please.
Sir, it's already shared.
Oh, Dr. Ghosh, I'm pleased to introduce Dr. Sebanti Ghosh, who is the Director, Country Program for Alive and Thrive, a new initiative into comprehensive activities related to saving lives, preventing illness, and ensuring health and growth and development through the optimum maternal nutrition, breastfeeding, and complementary feeding practices. It is managed by FHI 360 and is currently funded by Bill and Melinda Gates Foundation, the Government of Ireland, the Canada Foundation, and UNICEF. So we welcome you, madam, and now it's all yours for the presentation on preconception and maternal nutrition interventions. Welcome, madam.
Thank you, sir, for a kind introduction, and my congratulations and thankfulness to MS University Vadodara and all the organizers for organizing this wonderful event and giving us an opportunity to present. I would request the screen share for my presentation from the back-end team, please.
Priyanka, please share the screen.
I'm very glad that during this occasion of the World Breastfeeding Week that we are talking about investing in the entire spectrum, starting with preconception and maternal nutrition care. And this is very integral when we talk about protecting, promoting, and supporting breastfeeding, because the foundation has to be strong. Next slide, please. And this conference is talking about investing in the first 1,000 days of life. And this is the age of greatest vulnerability. It leads to stunted growth and development. And as one of the earlier speakers spoke about, undernutrition is not just about the physical growth and development, it is about brain development too. But we can fix it if we act in first 1,000 days. And let's just revisit the impact that we have when we act during the first 1,000 days. When we invest in maternal nutrition, we are laying the foundation stone for the child's growth and development. And it's not just about saving lives. Yes, we can save more than 1 million lives each year when we act during this phase of the life, but it spans beyond health and nutrition and outcomes to improve a child's school readiness, educational achievement, adult productivity as well. And we had started off using the nutrition inequity and ensuring equitable systems. And this is the phase, if we work during this time, we really can reduce the disparities that today we are faced with in health, nutrition, education, and earning potential. Because this is the time when we can really work towards breaking the intergenerational cycle of disease, malnutrition, and poverty. When we focus on first 1,000 days of life, that investment boosts a country's GDP by as much as 12%. The next slide. So let's just see, when does stunting take place? This is an August gathering, and I know most of you know about these facts, but it's good to always remember that evidence shows us that if we are taking this scenario where we are facing a 10 centimeter deficit at 3 years of age, the child is already facing a deficit of 20% at birth. Another 20% deficit occurs during the first 6 months of life, and 50% occurs during 6 to 24 months. And then another 10% during 24 to 36 months. So we have to work during this phase to stop stunting, because actions after 2 years, expensive, the impact is minimum. The next slide. So this brings us very much to maternal nutrition. We really need to understand fetal undernutrition. Fetal growth restriction, based on the scientific analysis that has been done globally, is one of the leading risks of stunting worldwide. And we all look at stunting as one of the major targets that we want to work upon, want to reduce. We do not want 144 million children in the globe to remain stunted. India has a huge burden, and if we have to act, we have to consider fetal growth restriction. The time matters. Fetal stunting is evident by as early as 8 weeks. And along with this, we must remember 70% of the brain develops in utero. So there is all the evidence which says why we should be looking at maternal nutrition. And it's also about the woman and what are the adverse maternal outcomes that can be avoided if we are investing in maternal nutrition and along with the maternal health care services. We avoid abortions, stillbirths, preterm labor and preterm birth. We reduce risk of mortality from postpartum hemorrhage, from preeclampsia and eclampsia. And yes, we look at the woman too. Its impairment of her reproductive and her productive capacity. And very important, the intergenerational consequence that we can avoid. The story is with the girl child. The girl child who is born small for gestational age or low birth weight, stunting in childhood, stunting in adulthood, poor nutritional status in adult life. In a context of India or South Asia, you will have other factors aggravating this problem with early marriage, early pregnancy. This girl child grows up to be having short stature and poor nutritional reserve as she is entering pregnancy. So we are building a foundation for not the right foundation, but a foundation for small for gestational age babies. Next slide. That's this is where we see the intergenerational cycle of women's undernutrition. So what do we, I think there is some.
Fatak, can you please mute your mic? Dr. Fatak?
Yeah.
आपका mic चालू है, please बंद करें.
Thank you, sir. So this is what we see. You know, what are the major determinants for low birth weight? It is the poor maternal nutrition status at conception. That's an important point. Then we come to inadequate gestational weight gain, which is due to poor dietary intake, short maternal stature, which I was already talking about. And annually, we know there are 6 million small for gestational age births happening worldwide, which is associated with maternal short stature. So that's the story. The low birth weight infant it continues the child growth failure. There is enhanced risk of childhood stunting with SGA and preterm birth. And this further continues in adolescence. And mind it, if it is a girl child, then the implications are very critical, because this failure in growth in childhood, in poor learning through poor cognitive development, the reduced chances, the reduced potential for reaching, a fully productive adult life, all getting diminished. And we are having an adult woman compromised in her nutritional status. And in between, for countries like us, we also face adolescent pregnancy, which halts the linear growth during adolescence. There is loss of weight and depletion of fat and body mass, and enhanced risk of SGA and preterm birth. And so this cycle continues. So we need to work across all the life stages. The next slide. So we have been talking about maternal nutrition, but less on preconception care. And we see that even in countries where we have a stronger public health system and programs which reach to women across life course, we very often see women are not entering pregnancy in good health. And this is very true for South Asia, for India, and there is evidence on what preconception care can impact. We will see reduction. This is what the evidence globally is coming out through, particularly WHO, that we will definitely see a reduction in maternal and child mortality. We will be able to prevent unintended pregnancies, potential to reduce stillbirth, preterm birth, and low birth weight, prevention of birth defects, particularly neural tube defect and neonatal infections, reduction in underweight and stunting, and also lowering the risk of type 2 diabetes and cardiovascular disorders in adult life. So you can see the link. So the evidence is very strong for both maternal nutrition and for preconception care. It is basically talking about look at the woman across the life cycle. So the next slide. These are recommended maternal nutrition interventions. These are very basic. These are core interventions that must reach all pregnant women. They are recommended through WHO, particularly emphasized upon in the 2016 updated ANC guidelines, which talked about positive pregnancy experience. It is there in our national programming, and we know about it. Just to revisit the same, counseling on healthy eating, a focus on adequate and diverse diet during pregnancy is very important, along with counseling for physical activity. WHO also recommends undernourished populations, balanced energy and protein dietary supplements needed for reduction in small for gestational age or low birth weight babies. The recommendation for micronutrient supplementation, iron and folic acid and calcium supplementation, provision along with counseling. We all know IFA supplementation helps in reduction of maternal anemia, sepsis, low birth weight, and preterm birth, and it also reduces the risk of maternal mortality from postpartum hemorrhage when underlying anemia aggravates the postpartum bleeding greatly. Calcium supplementation, the impact is on reducing MMR from preeclampsia and eclampsia. The other recommended interventions are around deworming in the second trimester of pregnancy and use of iodized salt. We know use of iodized salt helps in reduction of abortion, stillbirth, and for the improved neonatal outcomes by preventing brain damage, congenital defects, mental retardation. So these are known interventions already in our programming. There are newer interventions, recommendations coming up, evidence being built up. I'll mention the multiple micronutrient supplementation with WHO very recently, revising their earlier recommendations. So there is still a bit more of work around the recommendations, but these are core and they are based on evidence. The next slide, please. And what are the recommended interventions from WHO for preconception nutrition? It's counseling on healthy and diverse diet, micronutrient supplementation, especially folic acid supplementation. It is important that we undertake assessment of nutrition status and monitor the same in the preconception phase. It is important to screen and appropriately manage anemia and diabetes mellitus. We need to promote physical activity and exercise in the current context that we are now facing the double burden of both undernutrition and overnutrition and use of iodized salt. And it is important to note when we talk about intervention in the preconception phase, nutrition interventions need to be combined with sexual and reproductive services, including family planning, healthy timing and spacing of pregnancy guidance, and very much linked with programs which focus on women's empowerment, addresses girls' education, prevents early marriage. For the next slide. So as I was requested to highlight the evidence that is there for maternal and preconception interventions, which impact both the maternal and the neonatal outcomes from nutrition, health, and well-being point of view. I just would like to speak towards the end of my presentation that I am reaching now. In the context of these known interventions that we have, the evidence that is speaking to us so strongly, where are we in India? We have a favorable, mostly favorable policy landscape. Maybe a little bit more enrichment in certain areas is required, but we are mostly there. But the status of women's nutrition in the country is not at all rosy. So if you have almost 1/4 of your women, it's 23% women in India who are entering pregnancy underweight. And look back, girls in the age group of 15 to 19 years, 42% of them are underweight, having low BMI. In the reproductive age group of women, we have 53% of women who are anemic. And when it comes to adolescent girls, it is 54% of them being anemic. And during pregnancy, we see 50% of the women are anemic. We have 26.8% of women in the age group of 20 to 24 years who are getting married before 18 years. Adolescent pregnancy stands at 8%. And what do we see during pregnancy? Our health system is reaching with tetanus toxoid immunization to almost 90% women. Institutional deliveries is as high as 80%. But with IFA supplementation, when we have such a high burden of anemia, only 30% pregnant women consume the same. Average weight gain during pregnancy is 7 kg only. One of the key birth outcomes, we have almost 1 in 5 babies being born low birth weight in the country. So this is where we need to reflect and see the interventions that are recommended. How do we bring that evidence back effectively in our implementation? It is mostly there in our policy, but needs to be translated into action on ground at the last mile. Next slide. So while we prioritize maternal nutrition, we must be positioning in all our policy program dialogues women's nutrition across the life course. It will not be enough that we are acting only during pregnancy. And that's why we need a stronger discourse, both in policy and programming, for operationalizing, for bringing in and then operationalizing preconception nutrition care. And we had started off talking about integrated delivery through the existing system. So we have to be prioritizing that and use a systems approach when we are talking about integrating and strengthening the delivery of both preconception and maternal nutrition interventions, maximizing the opportunity that our existing health and ICDS platforms provide us. And we will need to address it with a systems lens. And we must be addressing multiple factors which affect the outcome at the end, at the individual level, at the household or family level, and the service delivery factors, so that we have maximum impact, so that we can ensure better health, nutrition, and well-being for not just mothers, but for the women in the country, and a smarter start for the future generation. And in this process, we have to bring to forefront quality when we are delivering. And we need to really address the social determinants of women's well-being. We need to address women's education, age at marriage, age at first pregnancy. It is important to address this, combine this with our system strengthening approach. The next slide. So thank you. And it is time that we really make women's nutrition aspirational to all policymakers, thought leaders, academia, civil society, and media. And we must fully understand this intergenerational cycle and its starting point. Thank you so much.
Thank you, Dr. Sevanti, for sharing the insights about the importance of continuum of care interventions to prevent the detrimental effects of vicious intergenerational cycle of malnutrition. I now request Dr. Bakshi to introduce our next speaker, Mr. Thomas.
Okay, next please. I'm pleased to introduce Dr. Thomas Forrester, Director Program Asia Alive and Thrive. He's going to tell us on strategic planning and management for the promotion, protection, and strengthening breastfeeding in Southeast Asia. And it will be followed by Dr. Binu Anand, National Team Lead, WeCan, New Delhi, India, who would be speaking on fostering partnerships to improve nutritional outcomes in India. Thank you. So Dr. Thomas is a management guru into strategic management, cross-cultural activities, field deployment, and is interested and is working as an expert on strategic partnerships to bridge public and private partners, and has led to some improvements in the global portfolio of TB, HIV interventions, blockbuster drugs and vaccines, and improving patient adherence and guiding management strategies. Thank you, sir. Welcome.
Thank you. Can you hear me?
Please.
Can you hear me?
Yep. Yeah.
Yes, Thomas.
Okay, perfect. And let me try to see if I can share my screen. Can you see my screen? Because it says that I'm sharing, but I'm not fully sure you can see it. Can you?
No, Thomas, yet not.
Huh. Let me try again. Can you see my screen now?
Yes, we can see it now.
Perfect. So I'm going to try to build on what was discussed in the prior presentation to talk a little bit about the how of delivering some of the interventions. And my apologies, I'm sure that there's some results that I will be sharing that some of you have seen before, but I think there might be a few ones that will be a bit new. So I'll talk a bit quickly in terms of what results can be expected from maternal, infant, and young child programs, and then describing what are some of the features that make a MIYCN program effective. And then more importantly, I'll talk about some of the recent data that has been generated on how to deliver on those features of an effective MIYCN program. So the data that I will share drives on evidence that comes from global evidence as well as some evidence across India. And the few randomized clinical trials that I will be referring to throughout this presentation pretty much says the same thing across a series of different indicators, including breastfeeding, maternal nutrition, etc., which basically shows that through interventions that combine, that are either only social behavior change communication, or that includes both social behavior change communication and some kind of a supply element, some kind of a food security element, you can get in around a year, when it's well managed, around a 30 percentage point improvement in terms of the exclusive breastfeeding, in terms of maternal dietary diversity, in terms of consumption of iron, folic acid, and calcium, or minimum diet diversity for the child. And so so basically what those randomized clinical trials shows that through an intervention that is actually doing the right thing for the beneficiary, we can actually generate the right level of impact. The important thing is really to make sure that the intervention is sufficient, and I'll be talking a bit more about that. So the way that we're currently describing a sufficient intervention is, of course, having the effective content of the intervention, including the SBCC content, but also the other services such as growth monitoring, etc. So that means really having the right policy, having the right channels in terms of home visits through ASHA, Gandwadi workers, VHSND, etc. But very importantly, having those in terms with the right coverage, the right continuity, the right intensity and quality, and that were summarized by Aryan, who was talking a little bit earlier in this acronym of C²IQ, coverage, continuity, intensity of quality of the intervention. And of course, adding to this, the right access to food. And the important thing is that this intervention, the way that they are delivered, they need to be really addressing the beneficiary behavioral determinant of knowledge, belief, self-efficacy, and social norms so that we can drive the nutritional behavior change that we're after. So quickly, some of the evidence, because I think this piece on the sufficiency is something that is starting to be well known in the community. Depending on the setting, depending on the nature of the intervention, the intensity, the frequency of interaction by the system with the woman vary, but is around 2.5 in some geographies, 4 in some geographies. Recent data that we have from India shows that 5 really has some kind of an acceleration factor. But the important thing is we need to have more than one. We need to have multiple interactions. The second thing that is really clear across all of the different evidence generation programs that we looked at is that it's much more effective if we have multiple different channels that are communicating the information, with a combination of mass media, interpersonal communication, and community mobilization generating the best results. But that different combination of mass media, IPC, or even IPC and community mobilization are really impactful. And we have some very good examples of that, for example, in Bihar with the Jivika program with self-help group. Some newer data that is starting to emerge is of the comparative importance of coverage and quality. Coverage in terms of the volume of interaction, and quality in terms of the content of the intervention that is actually delivered to the family. And so what you can see in this chart is that quality in terms of its odds ratio, in terms of impacting one measure of impact, the number of IFA consumed, is almost twice as impactful as coverage. The problem is that we have very little understanding, little grasp of how to really track quality in a consistent manner. And that's something that we've started lots of conversation. But I think that as a community in India, we need to spend our time really defining what quality means. What we have today is really from research programs, some features of quality that have been measured to be associated with impact, with time spent with the mother being one important one, but a series of different attributes in terms of number of topics that were actually discussed during the meeting, or the nature of the interaction being very important. What's really important is that we need to really reinforce the focus that the system has on quality, because although the effect, the orange side on the right, is much more important for an increment in quality versus an increment in coverage, so far the ease of implementation has been really much in the favor of coverage, because we're measuring it, because we're focusing on it, and therefore we've been neglecting a tad the quality of services, which is really something that we should ramp up our thinking of and our collective efforts to measure and to improve. Of course, I'll go quickly on this. Social behavior change communication interventions delivered by ASHA or by Gandawadi workers cannot really work effectively without having some level of food security. We've seen from various trials that when you're doing SBCC, you will improve a little bit the food security by just changing the way that the mothers procure food and making them procure easier to access food that is grown in the community. But still, it's very clear in this chart that you can see here that the more food access you have, the higher the impact of the social behavior change communication intervention will be. And this is something that is sadly very, very strongly reminded to us in this difficult time of COVID-19. And some trials, I mean, it's interesting, but some trials that have been actually comparing the relative importance of SBCC and intervention that are improving food access kind of conclude that the two are of equal magnitude. but that's for normal circumstances, meaning that in circumstances where you're in dire situation of food insecurity, like some populations are today, we're going to need to fix the food access issue before we can really make all of the benefits from the social behavior change communication. So we've been talking a little bit about what makes an intervention that touches the beneficiary actually impactful. So there is the arrow that leads to the beneficiary. The beneficiary receives a certain number of interventions, and then that drives some change in behavior that leads to impact. What's very important is that we're starting to think more about interventions as system strengthening intervention. We need to drive behavior change at various steps in the system, from national to state to district, district to block, block to frontline supervisor, and then frontline supervisor to frontline worker. Because very importantly, and we've seen it in some initial studies, and I'll share some results from that, the frontline workers have the ability to be extremely good providers, but they need to be convinced, they need to have the right self-efficacy. And so there's a big bulk of evidence that is starting to emerge in terms of what makes an intervention actually effective to change the behavior of the frontline worker. And so same thing as for the mother, we need to think about the knowledge, the beliefs, the self-efficacy, and the social norms. And we have tools, capacity building, supportive supervision, strategic use of data, incentives, and various elements in the enabling environment that we can actually improve to make sure that we're addressing the needs of the frontline worker. But we need to use all of those levers in a way that is really informed by a good understanding of frontline worker behavioral determinants. And this slide is showing some analysis of the beliefs and self-efficacy of a frontline worker in the context of a maternal nutrition intervention. And as we can see, there's very large variation in terms of the ability of the frontline worker to adopt an intervention and of the self-efficacy of the or the ability of the frontline worker to actually deliver an intervention. And so when we're actually capacitating, when we're supporting those frontline workers, we need really to understand what are their frames of mind and convince them as much as train them of the value of various components of the intervention. Because even if their knowledge is high, they're not going to deliver effectively if they're not convinced. And if they're not convinced, they're not going to remember for a long period of time. And so there's some interesting data that is starting to emerge in terms of showing the relationship between various investments in terms of training, in terms of supervision and incentive, with some metrics of the effectiveness of interventions, of MIYCN interventions, delivery by the frontline worker. And so we can see that training, supervision, and incentives are of roughly the same importance for driving the knowledge of the frontline worker, and training and supervision being of the same level of magnitude in terms of improving the services, and with incentives having some kind of a quite very significant impact on actually improving the services. The thing is, as we need to start thinking more about quality and not only about quantity, we need to start investing more into the training, into the supervision and the incentives. We've done a lot of efforts ramping up our training capabilities, making sure that our training are actually well designed, well tested, and well delivered. And therefore, the ease of implementation of training has been actually going up. But we still have some difficulties with the supervision and incentives, which really require that as a system, we're really starting to think. Yes? Hello? Okay, I'm about to finish. We need to start thinking more about investing in terms of improving the effectiveness of supervision. One quick note that is important is when we're thinking about incentives, incentives are very effective, but they're not mediated by frontline worker knowledge and motivation. They're mostly operating as procuring a service, and therefore they're very effective in terms of activating something, but they're also as effective as making something disappear the moment the incentive disappear or the moment that the incentive is not considered sufficient enough. And so it's very important that we're really thinking about the supervision and the motivation and using the incentive with caution. So some of the key takeaways. So MIYCN programs should balance the social behavior change communication and the food access intervention and all of the provision of commodities. The intervention should strive for C-square IQ for high coverage, high continuity, intensity, and quality, with a very importance needing to be given to quality at this juncture because it's been a bit the neglected element in the 4 elements. And then really we need to start thinking not only about beneficiaries, but more about frontline workers and frontline supervisors and managers as recipient of an interventions, because if we don't convince them, if we don't enable them, it's going to be difficult to actually make sure that we can change the behaviors, their behaviors, and in terms of behaviors of the families. So thank you so much for the opportunity to share those information with you. And I wish you a fantastic continued day and a half of this conference. Over.
Thank you, Mr. Thomas, for orienting us about the effective interventions for behavior change, especially the social behavior change communications delivered with coverage, continuity, intensity, and quality. We will take up the Q&A session towards the end, but request the speakers to answer the queries in the Q&A section. I now request Dr. Bakshi to introduce our next speaker, Mr. Binu Anand.
Screen.
Yes, sir. Yes, sir. Sir, it's taking little time to load.
It's fine.
Dr. Bakshi, this is Binu here. Since you had already introduced me, in the interest of time, I can maybe start, not a problem.
I guess so. Please. We save the time. I invite Mr. Binu Anand, a public health professional with experience in Bangladesh, Pakistan, Indonesia, Philippines, and India, and is an expert in program management. And here he is talking about fostering partnerships to improve nutritional outcomes in India. Mr. Binu Anand, please.
Thank you so much, Chair. With your permission. I see the time we have crossed 1 o'clock. I really don't want to be holding people when they're hungry. It might really not go in the right taste. So I'll keep to my time or even shorter. So to talk about partnerships, which I believe is slightly non-technical content, because we have a lot of experts talking about technical content with us. So I think we'll keep this session a bit lighter, but I think talking of partnerships is very important at this point in time, talking about how we can achieve the ambitious targets of Poshan Abhiyan. As the name suggests, WeCan. We collaborate for nutrition. We collaborate for nutrition, which is like a platform which fosters partnerships, collaborations, and work in coordination with partners. But before we get into the entire discussion, I would want, had this been a physical kind of a get together, I would have wanted participants to get up from their seat and do a bit of energizer and then come back to their seats. But instead, now what we would do is a bit of a brain exercise. I would really want to understand from each of the participants as to what do they understand by partnerships and collaborations, and what are their expectations, from a collaboration when they get into partnering with somebody. And looking at what is happening across the country, across the globe, are we sharing knowledge? Are we learning from each other? Is that enough? Is that something that we would want to understand? Because before I get into what partnerships are about, how do we operate in terms of getting the different learnings and all that onto a platform, it would be important to understand from all the partners and all the participants, what do they understand by all this? I would urge all of you to take your phones out or your laptops on, go to www.menti, M-E-N-T-I, menti.com, and wait for the code. I would request my colleague to play the question and the code on the screen, please. Can you have it as a presentation mode, please? All right. So if you look at the question, what do we understand by the terms partnerships and collaborations? It's an open-ended question. Please feel free to write in your answers. And the code is 356157. Please enter 356157 and type out your answers. We have about 179 participants. So we would expect at least over 100 people to respond to this. Just keep writing and submit it. It could be a one-word thing. It could be a sentence. Keep it as short as long as you want. It's your choice. Go on to your mobile phones, open a Google page, type www.menti.com. It'll ask for a password, a code that is 356157, and just keep typing in your answers. Perfect. Fantastic. I've got 2 responses already. What do people understand by terms partnership and collaboration? Equal learnings from each other, working together for a collective goal, 2 entities working together towards a common goal. I see common goal and collective goal coming together. Good. Sharing experiences, knowledge, and forging common goals for public good. Not working in silos, sharing information, easily connect 2 mediums, a relationship between 2 or more, exchange knowledge, working together, mutually working for a passion, good, working together. Great, great. I think quite similar in terms of responses. I have a longer one. Partnership is when 2 people work together and have equal share in the venture. Collaboration means getting along with many stakeholders with different skills. Perfect, fantastic. Cooperation sounds good. Cross learning, I like that. We have got about 26 people responding as of now. Good, 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 good. I would really be interested to really know from each one of you, if you guys are hungry, we can move on to the next one, or else we kind of, still continue taking more answers. I would love to see about 100 answers, but I think I like this, no ego. That is something that we as an organization kind of, push across all organizations, across all platforms. No logos, no egos, and then we would really want to promote that culture of no egos and no logos. That sounds really in line with our thought process. It's good. Partnerships working together for common goals and collaborations are when we converge together and contribute in our own domains. Perfect. Teamwork. But I think it's good. I think it's good. We are getting kind of a very similar pattern in the responses. So I, in the interest of time, would not kind of linger on with this question for longer. I would request Drishti to kind of put the next question on, please. Anybody who's not got the code, it is 356157. And the website is www.menti.com. Drish, can I have the next question, please? Well, I think with the previous speakers, you would have seen there is a kind of a clear-cut requirement in terms of looking at partnerships. I think Meenakshi ma'am touched upon in the partnerships and convergence at some point in time. I heard Dr. Gayatri talking about the C-square IQ, which is a continuity, coverage, intensity, and quality aspect of the nutrition work that we do. So there is a clear call out for a lot of coordination and collaboration between partners. And as we kind of go forward, we will unpack more as to how we as a team of a group of professionals in the WeCan kind of unpack the entire collaboration and coordination efforts we do at the national and at the state level. Drishti, can I get the next question, please? Priyanka or Novina, if you guys could kind of come and help getting the next question on.
We are not able to get the second question on our screens also.
Yeah. I think there is some technical problem in terms of getting it loaded. I am also waiting for it. I really don't want to be kind of taking time on that particular aspect of it.
But it's very good idea to be very clear on what these words really mean and how to make it operational. How do we work together?
Absolutely, Meenakshi ma'am.
Complement each other.
Absolutely, Meenakshi ma'am. Basically, the point is to have that kind of an alignment with the participants and their thought processes, so that whatever we talk is in perfect alignment and kind of people are on the same page at the end of the day. So I think perfect what you said. Can I request Bhaskar to not share the screen and let Drishti do it, please? Okay, I think the website has got hung or something. I think that is the issue here.
Just a second, Binu, just wait for a second.
Okay, so basically, Priyanka, what I think is in the interest of time, if we are not able to project it, okay, sure, thank you. Okay. Sorry, I don't see the question there. All right, guys, I think we have taken enough time and we can't keep the participants waiting. Can I request that we play the PPTs now? Maybe we can get into the Mentimeter poll later on at some point in time.
Binu, can I share the screen?
Yes, please. Bhaskar, please go on.
Yeah.
Thank you. The PPT, please.
Shall I share the this one slide, Menti?
Slide 3 and please.
Slide 3.
2. Yeah. All right, maybe I don't know if it's something at my end that I'm not able to probably see on my screen. I'm sorry though. Can we get into the next slide, please? Next, please. Yeah, that's fine. So basically, WeCan is a national level platform which kind of forges collaborations and partnerships with similar minded organizations working in the space of nutrition across the country. And how we kind of collaborate is probably through multiple channels, and some of them are the C Square IQ platform that at some point in time Dr. Gayatri had spoke about, which is coverage, continuity, intensity, and quality around nutrition action across the country. We have a multi-utility digital platform in the form of nutrition platform. We'll come to that, and I'll kind of take you through in a bit more detail about it. And we come up with wonderful process documents which goes in depth into the processes involved in each of those successful interventions, which are scalable, replicable, and have high impact across the geographies it is being implemented. And we share it with partners on different platforms, as in when we get opportunities across. So next, please. Talking of C Square IQ, this was a concept which was discussed and coined. I think it was led largely by Aryan in terms of coining it as C Square IQ. But I think it was a long discussion and deliberation between partners from BMGF, UNICEF, of course, World Bank, Alive and Thrive. Thomas was part of it and his team. So all partners at the national level came together. I think we had Tata Trust and all those people putting their brains into trying and understanding what is the current need at this point in time, looking at how the country needs to be achieving nutrition targets, especially with the rollout of Poshan Abhiyan and a need for achieving Poshan Abhiyan targets on time as planned. And that is when we thought, every partner is doing wonderful job in their own geographies, in their own thematic areas, but in strict silos, and other partners working in the same geographies near them are also not aware of what is happening, how they are doing. So there was very little cross sharing, cross pollination happening. And I think that was where it was decided that all the partners working in the nutrition space come to one platform at the national level, and then we kind of take this entire effort cascading down to different states. And the first national level C Square IQ meeting happened in Delhi in June 2019. And I think we had organized at least 20 plus organizations of national repute who participated, with over 150 people spanning across 2 days, trying and understanding how we could get all the partners together across different states and work together with one agenda of supporting the government in achieving Poshan Abhiyan targets. And since then, I think there was no looking back. WeCan as the platform took over the C Square IQ in partnership with Alive and Thrive, CFNS, Coalition for Food and Nutrition Security, and UNICEF. And we've been taking it to all different states. And currently, we have completed at least 13 state level meetings in 6 states. And the new states that are already kind of in discussion with us, Assam is interested. Yesterday, I got a call from Andhra Pradesh that they are interested to have all the partners together to come to one platform to try and understand who's doing what, where, and how can these synergies be brought together and support the respective state governments in achieving their targets. And that's exactly what we're doing. Even if you look at today's event, we and MSU are kind of joining hands, bringing Alive and Thrive and other partners together. And this is the DNA of WeCan. We don't do anything by ourselves, by us. We kind of get partners. We take it as a joint effort, and with giving enough space for each partner to operate, we kind of do it together. That's exactly what we want to be taking forward as well. We'll quickly glance through a few examples, including Gujarat, to make you, give you an understanding of what happens in a C Square IQ kind of a gathering. Next slide, please. And I should also kind of, tell you guys that at this point in time, with the COVID happening, the lockdowns, the travel restrictions, no gatherings, physical distancing, I think we kind of took that as an opportunity and shifted our convenings onto the digital platform. And like how this webinar is, the symposium is happening, we kind of have our C Square IQ meetings on a similar kind of a format, where we get partners to come online, and we have all these gatherings happening, on digital platforms, where a clear-cut, detailed agenda is laid out for partners to contribute into, and we look at the priorities of the state, and then we kind of work around that. in Jharkhand, if you look at it, the nutrition partners meeting initially happened as a physical meeting where I think about 18 organizations came with about 40-50 odd people in it. The first step was to try and identify what could be the priorities for the state, and narrowing it down to maybe the top 3 priorities, and working around that in terms of developing a joint action plan, joint monitoring tools, joint visits, and then collate all this information on a periodic basis, put it together and share it with the government, saying that these are the areas that we identified. Some of these things are working very well, so it needs to be kind of continued as it is. These are the areas where you need to put in more resources, support more, strengthen them. So that kind of a mechanism was something that we were trying to evolve. But with the COVID coming in, we moving on digital platform. The first thing that we did was trying to do a landscape analysis across all the states to understand how is the nutrition service delivery faring at this point in time vis-a-vis the COVID pandemic that we have. And then subsequently, we kind of worked around plans to give kind of directions to the government, saying that okay, these are areas where we need support because services are not being met at the way they are supposed to be implemented. So those kind of advocacy pieces were worked upon and submitted to the government. And of late, once things started kind of falling into place, getting a bit regularized, normalized, again we were trying to look at what are those big pieces of work that really needs focus. And in Jharkhand, across the states, you would see complementary feeding coming as a big piece of work. And now we are at a stage where we have developed tools adapted from other states, inputted by the state partners. We have kind of developed it as per the local requirement, and now it's being kind of shared with the partners and the government, and it is being implemented. So that is how the whole effort works together, bringing all partners together. Can we move to the next slide, please? Similarly, in Gujarat, the difference was in Gujarat that we started this discussion with government of Gujarat. Manisha ma'am was like very kind to have these discussions with us and try and understand how best can we get partners together to support WCD to kind of take their work ahead in terms of doing field level monitoring, supporting Anganwadi workers and Anganwadi centers, and building their capacity, strengthening them, giving that feedback or real-time feedback back to the department on a regular basis, on which the department could kind of take actions and kind of plug in those gaps. And at this point in time, we are at a stage where we are trying to support DWCD along with Alive and Thrive in those key priority areas identified. Even if you kind of remember what ma'am said today, she was like focusing more on adolescent nutrition, urban nutrition, areas around quality. So I think these are the big ticket items that probably Alive and Thrive and WeCan would kind of support DWCD in Gujarat. Next, please. Similarly, in Uttar Pradesh, there is a UPTSU funded by BMGF. We kind of, are working closely with them. A similar exercise was kind of done there, getting all the partners on board. We looked at what could be the priorities for them as well. And couple of things that, came up on the list again was looking at household convergence through different mechanisms. And, we were trying to share our experiences of capturing learnings around how PRIs are involved in getting that last mile service delivery done and the connectivity done. And now we are at a stage where UPTSU is exploring in detail as to how that last mile convergence could happen, the household convergence could be done, and we are kind of supporting as a unit, WeCan, ANT, and all of us together. So that is how the C2IQ kind of evolves over a period of time, where partners share and contribute to their learnings, which we take further across the state and beyond the state with other partners. Next one, please. Sorry that I'm hurrying up a bit because I see a lot of time wasted, and I see we are running almost pretty late in the session. So I'm just kind of trying to make up as much as I can from my end. Talking of nutrition platform, this is something that again WeCan is developing with the support of other partners like IIT Mumbai, CFNS, Alive and Thrive. This is a kind of an online platform. You can see the URL. I would urge each one of you participating in this event to visit that website once to understand what it entails, apart from what I'm going to be talking about. The URL is www.wecollaborate4, as in numerical number 4, nutrition.org. Basically, the platform is a very neutral platform, open for all to access, upload your content. It also has something called as a mapping, atlas kind of a section which looks at presence of different partners across different geographies, working in different thematic areas and sub-thematic areas with own their experience and expertise. So you kind of get to put your profile onto the atlas, which is seen by all partners and donor community, government, the departments, everybody and anybody who's interested to know and understand more about presence of partners and the areas they work. So this kind of presents a unique opportunity for partners to showcase their work in a manner that can kind of both ways lead to cross learning, but as well as also attract interest of people and donors who would want to kind of invest in a certain geography on a certain thematic area. So if you wish, you could visit the website and have a look at it to understand. The platform also has a wonderful nutrition radar, which is basically the NFHS 4 data analyzed and developed by IIT Mumbai, the CTARA department, and kind of displayed out on different indicators as how each of the district and up to the block level, how do they fare. So you can go and see if you have a particular interest in a geography to understand how that particular area or geography looks like vis-a-vis the NFHS 4 data. Similarly, there is a section called Portion Stockroom, which in the real sense of stockroom means we have loaded it with documents and reports from different sources, including our own C-square IQ reports and all the material that we could gather from different sources to let people come to one place where they can access information about different thematic areas and sub-thematic areas about nutrition. And in one click, you get the information that you want. And we would encourage each one of you to upload your own content, reports, and other guidelines that you would kind of can access onto the Portion Stockroom, that so that there is one place where any partner or any individual, any scholar wants to come and access information. So please do that. And over a period of time, I think we would also be having e-learning courses being launched on the web platform. Anybody who's interested to kind of register for a e-learning course could just come to the website and look at the different options available with different organizations and just connect to them and kind of continue whatever you wish to do. And in the interest of time, I would not linger on more on the nutrition platform. Rather, I would suggest each one of you to please visit the website and have a look at it. Next slide, please. Practice insights are a set of documents that we create, which looks in depth about the processes involved in implementing a particular intervention and seeing how the processes led to the kind of outcome that was expected, and in the longer and larger sense of it, how it impacted what was expected. So the documents are very clear in ways how it describes the methodology and the implementation processes, so that anybody who wishes to implement any learnings in any geography, anywhere, all that you need to do is pick up one of the practice insights, read through it completely. And we are also now giving you a backup product, which would be in the form of animation or a documentary video or sometimes a podcast, which you can just pick up, listen, see, or understand what it is and adapt those learnings and implement it in your geographies. And we are kind of urging each one of you sitting in this symposium to subsequently share any of your interesting implementation stories that you have, or any implementation models that you have you think has created impact and you would want it to be captured and for people to know more about it. Please do let us know. We will be more than happy to capture it for you and share across. Another part of these learnings is that we have been capturing a lot of stories and a lot of practice insights, which we kind of put it in a human interest angle, and we share it with Outlook. And Outlook has a nutrition magazine called Portion Outlook, and we have been regularly kind of sharing our stories and learnings with them, and they've been continuously being published. So I would urge again, all of you to kind of share your stories, which we can again share with Outlook for larger audience to see. Next, please. So these are a few examples of the practice insights that we have developed over a period of time. Some things are on engaging the PRI members for promoting nutrition action and achieving Poshan Abhiyan targets. Some work is around strengthening micronutrient supply chain, like how we did it in Jharkhand. That is our direct implementation. There was one that Chai did in Madhya Pradesh. So different stories are being captured, and there is something around how agriculture has been related to nutrition promotion, and that story has been well crafted, that happened in Odisha. So these are different practice insights. All of this is available on the platform, on the nutrition platform. Please access and feel free to read them. Next, please. And I think this particular symposium gives us an opportunity also to call out to each one of you sitting there. There's a lot of work happening around breastfeeding practices, improvements, and a lot of counseling and all that happening. I would urge each one of you to kind of share your stories back to us, and we would be more than happy to capture them and share with the larger audience. And students, please feel free to write to us to understand more about what we do, and we'll be more than happy to kind of support you in whichever way is possible. It's a very neutral platform, bringing all partners together and supporting all of them as much as we can. Can we have the last slide, please? So the call out is come and collaborate at wecollaboratefornutrition.org. Thank you so much.
Thank you, Mr. Binwanan, for highlighting the way forward to collaborate and partner to work together as a team to achieve our common goals by Countdown 2030. I now request all the speakers to turn on their camera for Q&A session. Due to the time constraint, only 1 and 2 questions will be answered. I request Dr. Bakshi to summarize and ask the questions.
Okay, the session 2 went off very well, and despite the time constraint, the last session went off like a rapid fire round, but was very interesting and very much inviting to the cause of nutrition care. In the first session from Dr. Savanthi Ghosh, the focus was on fetal growth restriction, the care during the first 1,000 days, the life cycle approach, and intergenerational approach to nutrition. And I almost thought that she was trying to tell us that just as you put the reproductive rights into her hands, now try to put the nutritional rights also in her hands as soon as possible. Maybe the challenge is start with the birth of the female child. The second session, second lecture was by Dr. Thomas. He gave the evidence-based importance of softer aspects of nutritional education and training, and gave statistical evidence to what is generally to begin with waffle. And I am extremely thankful that he could prove the point statistically and make sure that we really understand C2, C-square IQ, and the importance of all the different components, and then subsequently emphasizing on the need to incentivize and the need to focus on the training of trainers. The beneficiaries are not the point to be focused on, but it is on the provider side also that we need to focus when we talk of behavior change communications. With that came Dr. Binwanan with some hiccups. It was a rapid fire round, and he was very much inviting to experimenting with and exploring the website and sharing the experiences, because he emphasized on collaboration in whatever capacity that we may be working in the field of nutrition. So with this, I open the session for questioning to the expert who presented the second session. Thank you. Thank you, all of you.
Can I start off asking Binu and others, all those who are supposedly our funders? Can I ask one question? Can I begin?
Yes, please.
Yeah. See, I have listened to Aryan many times on C-square IQ, and the one very important aspect about C-square IQ is continuity. Now, I am only speaking from academic perspective. When we get small projects or whatever, the continuity part is a bit of a problem, because we get, say, for example, UNICEF, they fund only for 6 months, and then again you have to start with something fresh again. So when we talk of continuity, should we not have long-term partnerships where we have our common agendas and common goal and have a time to really achieve those agendas and targets? This short term is, small fixes we can do. We can't really do much of a, intensive, collaborative and continuous and intense effort. So I would like all the ones alive and thrive, maybe Binu, and if Aryan is there, Gayatri I think is there. If you could just think of what is the way we can have continuous interactions and continuous support so that we can achieve our common goals over a little long horizon, not 6 months horizon. Thank you.
Well, Meenakshi ma'am, to kind of quickly respond, although I would urge and encourage my colleagues, Thomas, and maybe my teammates as well, who kind of work very closely on C2IQ agenda, to kind of respond to what I'm saying and, kind of add more. Ma'am, basically, see, the point is, first of all, I don't think, apart from a few big donor agencies, any of us are donors per se. And largely what we kind of bring in is the kind of expertise and skill sets we have in either technically or in the kind of management and bringing around all these people and resources together, and then kind of support partners and the state government. So first thing is that none of our actions are short term. We are not looking at any sort of a short term arrangement in the first place. Second is, ma'am, the whole idea of getting the partners together in each of the state and not we kind of getting into the state and having a resource there is to kind of get that kind of ownership from and the buy-in from the partners who kind of understand the value of this kind of a partnership and partners coming together and keep leading the whole process and kind of fall back on us as and when required in terms of whatever support, not essentially financially, but any sort of a support that they want. For example, like this particular event, if you look at it, we said we can do ABCD things. You said you will do XYZ things. So that kind of a coming together with the resources is the kind of collaboration that we're looking at. But for specifically, when we talk of C2IQs at the state level, what we expect partners to do is we always identify a couple of lead organizations in every state. And we say, because you have been there and you've been leading the nutrition agenda in the state, like UNICEF's and the NIs in specific states. It could be Save the Children or World Visions. So the point is to ask them to kind of lead, bring the partners together, and have a kind of a sustainable arrangement, even if tomorrow we are not there. This kind of an effort keeps going on. So that is where we kind of bring the support system into play. But I think it is largely something that the state teams should be leading, and we can be there as long as resources permit us and time permits us. But at some point in time, it has to be either development partners led, or maybe, like for example, in Gujarat we have NGO coordinator in NHM, and even there is somebody managing NGO partnerships in ICDS. I would kind of expect at some point in time departments to bring partners together to try and see who's doing what and what kind of support can they look at, and what the partners can kind of get support from the government. That sort of an arrangement. So that is where I would stop. I would request others, Thomas, Shebanti, and others to kind of respond if they wish to add. Thank you, ma'am.
Nothing from my end.
Sir, we cannot hear you.
Hello?
Yes, ma'am.
Yes, can you hear me now?
Yes, ma'am.
No, I just said Binu said it well summarized, nothing more to add from me.
Okay. So we close the session. I thank you one and all present. We have come to end of our today's first half of the session, and I would request you all to kindly join at 2 p.m. after the break. Thank you.
Thank you.
Thank you.